Okay, I think out of respect for everyone's time, we can probably start. Welcome everyone to the Clinical Trials Network Translation and Implementation Special Interest Group. That'll be the last you hear of that. The next round will be all acronyms. So just wanted to give you the full definition. It's a grassroots group. It's been up and running for a few years, and we continue to welcome new members and established members, and I think it continues to be of interest and use to one another, and I think to the CTN writ large. So if you're new, welcome. Keep coming. It looks like most of folks on the call I recognize. So. But if you are new and kind of want to extend the invitation to other people in your networks, please do. I think we have a few things to talk about. This is an hour-long meeting, and it tends to go pretty quickly. First thing I wanted to do was welcome Dr. Hall Vo, who has actually been a member of the SIG, really maybe from the beginning, including serving on one of our work groups, and now is in a kind of a much bigger job. And Dr. Vo, I don't know if you wanted to say anything or share anything, but but please feel like you can.
Thank you, Mark. It's a pleasure to be here, of course. And I just I'll echo the sentiment that I've sort of tried to attend this meeting as much as I can. But more than that, I think I've also occasionally, when I've got the time, always go into the Grand Rounds link on the website and would always listen to some of the prior recordings of the presentations that are there, and I find it very helpful and useful. So in whatever role I have at the clinical Center for Clinical Trials Network, I think this is a big initiative, and it is something that we want to integrate as much as feasible. And so we're glad to be here. And obviously, Kristen Hundley, our acting director prior, was also a part of this working group. So trying to take on her role as much as feasible while also doing the other functions. So if there's anything that I can do, I'd be happy to contribute to this working group. And thank you for having me.
Well, always welcome. We're grateful that you're here, and of course, even more grateful for your leadership and hopefully a vision for for greater translation and implementation and sustainment of all the kind of things the CTN discovers. So really welcome, and appreciate your advocacy too. I think some of you may know this, but we recently, by we, I don't mean me, I mean a team of people leading a work group, Joe Glass, Sophia Gonzalez, Jen McNeely, and others, completed a review of CTN protocols over the past years and identified several projects that were kind of exemplary in examining implementation outcomes, not just effectiveness outcomes, but implementation outcomes. And the project that you're going to hear more about today was one of those, one such study that really kind of, walks the talk and walks the walk, that really shows how it can be done and really how the field can change as a result of this kind of work. So I want to introduce my two colleagues, Dr. Gail D'Onofrio, who's really a leader in the translation of addiction care in routine medical practice, and what she's going to be talking with us today is specifically in emergency departments. She's the Albert E. Kent Professor of Emergency Medicine and Professor of Medicine and Public Health at the Yale School of Medicine, and is really a fantastic leader in our field. And it's really great to have you with us this morning or this afternoon, Gail. David Fiellin is Professor of Medicine, Emergency Medicine, and Public Health, also at Yale. He directs the Yale program for addiction medicine and is the Vice Chief of Faculty Affairs and General Internal Medicine. And like Gail, is also kind of a totemic leader, I'll say, in our field. And both have advanced our work, our field, our understanding, our research, and kind of integrating addiction medicine into kind of the big house of healthcare. So we're grateful actually to both of you and your service to the field, and I hope your services to the field is going to continue. And we look forward to hearing about this project, and I think everyone is excited about how you've done implementation in the context of a more traditional project.
Okay, thank you. I want to be sure, are we sharing now?
You are.
Yeah.
Okay, perfect. And David and I are going to go over this primarily in the relationship to 69, which was implementation of ED-initiated view. Yeah, it's not. Hold on one sec. Okay. And I'm going to talk a little bit about 99 if we have time at the end, but we have no disclosure except for our funding. And then I'm going to let David go on. And David, I'll move the slides for you.
Great, thank you. Appreciate the opportunity to be here. I look forward to discussing with the group today. So as a way of background, probably no news to anybody in this group, but untreated opioid use disorder is an escalating public health problem. And we know that patients with untreated opioid use disorder frequently receive treatment in the emergency department. Sometimes it's related to complications related to their opioid use, or it could just be for a general medical condition such as asthma or pneumonia. And in 2015, we published a paper in JAMA that demonstrated that buprenorphine initiated in the emergency room, along with a brief intervention and a referral to ongoing care in primary care, improved engagement in formal addiction treatment at 30 days, also reduced illicit opioid use at 30 days. Next slide. So the challenge was how to think about implementing and disseminating this to a number of emergency departments. CTN 69 used the current hybrid type 3, which allows a focus on impact of implementation interventions really over the effectiveness. We felt as if the effectiveness could be presumed given the effectiveness of buprenorphine. But this was pretty bold because it was built after only one RCT providing evidence, and we could have attempted to replicate that RCT in a number of sites and focus on effectiveness, but we opted to choose a focus on implementation. And I believe this was the first trial within the CTN that really used a formal hybrid design and focused primarily, or primary focus was on implementation. Next slide. So the study team involved dyads, including the lead investigators, Gail and myself. And the dyads represented an emergency department principal investigator and a community practice principal investigator. And one of the lessons from this work is that, not surprising, most of these entities work in silos and were not typically aware of the work that was taking place. For instance, the community practice providers weren't typically aware of what was going on in the emergency department. And likewise, the emergency department did not have a good concept of what treatment in the community might have looked at like, other than perhaps detox. The sites were the University of Washington, the University of Cincinnati, Johns Hopkins and Friends Institute, and then the Mount Sinai Beth Israel site in New York. And these are the 4 sites that we conducted CTN 69. Next slide. So our specific aims were to compare what medicine usually does to disseminate findings in the field, which is a grand rounds presentation. And we decided to compare that to the implementation facilitation that I'll describe in detail. As you know, grand rounds is sort of the standard format in medicine and emergency medicine. And in this trial, our lead investigator, Gail, went around to the 4 sites and gave a grand round, spent time interacting with faculty and even provided resources as part of that as a implementation strategy. Now, we compared that to implementation facilitation, which is also known as practice facilitation. And this is the work based on Joanne Kirshner and Mana Ritchie. The primary implementation outcome was a combined outcome of ED-initiated buprenorphine receipt and referral for ongoing treatment in the community. The primary effectiveness outcome was engagement in formal addiction treatment, which we defined as an ASAM level 1 through 4, and this excluded engagement only in mutual help, 12-step or sober living. And it was important to recognize that since emergency department visits are fairly brief and it might not allow the clinician to make an overall determination of what the appropriate level of care would be, we wanted to make sure that we included a range of addiction treatments and not just one treatment or level of care as meeting the appropriate outcome. Next slide, please. So this slide helps you see the timeline and overview of events. We used a modified stepped wedge design, and you can see starting on the left, we've got our 4 sites, and then each site went through what's called a baseline evaluation period. Then they received the initiation of the implementation facilitation. The implementation facilitation continued through the second evaluation period, which was the IF evaluation period. This was the design of a stepped wedge was chosen because it allowed and ensured that each of the sites would receive the implementation intervention. And it also was consistent with the resources that we had at hand. We potentially could have done 20 or 30 sites, but since the lead node was acting as external facilitator, we really needed the amount of time that was allotted to devote to each individual site rather than being spread across a large number of sites. Oh, just go back one slide.
Sorry.
In the future results that you see, we're going to be primarily comparing this baseline evaluation period before implementation facilitation, which is in blue, to the green, which is the IF evaluation period and findings across that. You can see on the right side, down for sites C and D, there's a period that says pause, and that reflected one major challenge to a stepped wedge design, things in the world such as a COVID pandemic. Next slide. Our populations were twofold. We focused on clinicians, and we created 2 patient observational cohorts. The primary methods that we used included qualitative methods and focus groups, which were conducted by role. So for instance, physicians, nurses, social workers, patients, and by location. We also conducted quantitative methods using surveys that we're conducting at each site during each of the evaluation periods before or IF baseline evaluation period, IF evaluation period, and following the IF. And we compared 2 sites, 2 locations, both ED and community. So we conducted focus groups and surveys, both of individuals that were reflected in both patients and clinicians in the emergency department and patients and clinicians in the community treatment sites. Next slide. The clinician data was collected, as I mentioned, using both quantitative and qualitative. This was guided by the Paris framework. Those of you who are familiar with the Paris framework know that it's focused on evidence, context, and facilitation. We compared organizational readiness to change, or the ORCA, which was developed by Christian Helfrich, and a readiness and preparedness ruler. And then on the right side, you can see we conducted the focus groups both in the emergency department and in the community sites. Next slide. So I'll just briefly describe what was a lot of work, and that is the implementation, facilitation, implementation, intervention. This is, IF is often described as a bundle of activities that are tailored to meet the site's needs. This, as I mentioned, occurred during the IF period and continued through the IF evaluation period. The CTN lead team served as external facilitators for each of the sites. We conducted 3 formative evaluations, pre, during, and post IF, sort of, to identify barriers and facilitators. How's it going to work? How is it working? How'd it go? Is the way I sort of frame that. Again, this is all guided by the Paris framework and included web-based surveys, focus groups, as well as email and telephone follow-up. We identified local champions, although we didn't provide FTE to those local champions. We took advantage of existing staff that were already interested and committed to this area. We tailored the intervention to each site. We did formal academic detailing, which is a process of providing unbiased peer education to clinicians. And this was provided both virtually, telephone, and face-to-face between the lead node and the site clinicians. We created a learning collaborative where once a month, ED clinicians would log on and learn from other sites, learn from each other, and learn from the lead node. And then we also encouraged each site and worked with each site to develop performance monitoring and feedback using their electronic medical record to see how they were doing with respect to providing buprenorphine for individuals with untreated opioid use disorder in their emergency departments. Gail, I'll hand it over to you.
Great, thank you. So overall implementation about what we looked at, querying electronic medical records and evaluations. This is what we found over that period of time. I'll show you this in 2 different ways, but you can see that the baseline evaluation is in blue and the IF here is in green. And for all sites, this is the number of ED visits where buprenorphine was initiated. This is just throughout the entire time period, pre and post. And you can see there was a large number increase after the implementation facilitation occurred. And in some sites, there was like nothing before, and at least there was something. And I think really I want to emphasize that we started this in 2017, and the paper was just published in 2015, our original work. So this was really quite shortly afterwards. And as you know, it usually takes 17 years to make anything happen. So this was maybe it's not as best we wanted, but it was pretty good. We also increased the amount of unique ED clinicians that were prescribing buprenorphine from 162 to almost 450 in the IF period. Other things that we did was overdose prevention. So we looked at how much naloxone was distributed or prescribed pre and post. And of course, we no longer have the waiver, but you can see that so many people were waivered then, at least then, so they all had the education. And that was also not just our physicians, but PAs and APRNs who received certification. So we look at the patient now observational cohorts. Again, we had the primary IF implementation outcome that was patients receiving ED with referral during that period of time. And then we had the IF effectiveness outcome was whether or not these individuals were engaged in formal OUD treatment on day 30 post-enrollment. And that was again based on treatment facility clinical record review. And patients were included if they met the DSM criteria for moderate to severe opioid use disorder. They were 18 years or older, and they had to have a point of care testing positive for opiates. They were excluded if they were non-English speaking. They required hospitalization. They were not able to participate because they were cognitively or had a severe medical condition. They required opiates for pain and the usual types of thing, that they were in police custody or they were currently 30 days enrolled in OUD. So if they were enrolled in the past 30 days, we did not. If in this study, if they were excluded, if urinary test was for fentanyl, only because this wasn't an approved test at that particular time, so we really couldn't use it, which back then may have eliminated some people, but not a tremendous amount. And here you can see we screened a lot of people on the baseline and in the evaluation period. So we had almost 27,000 in each different group. Many people were ineligible, mostly because they didn't use opiates. If they were eligible and not enrolled, that was primarily because they didn't want to be consented to be enrolled. And by the way, why all this is going on in the baseline evaluation period or in the IF period, the clinicians really didn't know what we were doing. They had these people rolling around all the time looking at patients, so they were not aware of what the objectives were of this trial. So we enrolled 394 in the baseline and 362 in the IF period, and those were all evaluated for primary and secondary outcomes. In the summary of patient characteristics, which are really true to even in our continuing 99, which we've done post this, was very similar in that 3/4 of them are generally male. As you can see, their ages are in their late 30s or 40. They're a relatively diverse group of people in that 50% approximately were white, 30% were Black. We had some patients, but few American Indian or Alaska Native, and about 11 or 12% were Latino. As in, again, other studies, many of these were unemployed, so around 50% were unemployed. Few were working now, and they were a very vulnerable group. As you can see, 63% were either in a shelter or living in the street or in transitional housing, which is pretty much what we're seeing all around. 3/4 of them were on Medicaid, and many of them did have an overdose in the past 30 days, reported non-fatal overdose, and about 20% of them required intervention. So if we look at overall by site, actually this is not kind of showing up. It's not doing its thing. Well, okay, I don't know why that's not working. All right, well, anyway, we're gonna have to do it like this. This is not working. I don't know why that's not working. It should have passed on to here. All right, well, anyway, I can tell you about this. Anyway, overall, by site, we looked at before the patients who were just give me 1 second and I can do it. Why that's doing that way. We already talked about how many people overall had prescribed. And then we looked at patients who were engaged in OUD. And the baseline, we had around 40% of patients who were engaged in OUD treatment. Yeah, if I can do it here. Yeah. Anyway, we already showed that there were so many more people who got treatment. And this is probably the most kind of important thing that I can tell you about, is that those people who were engaged in treatment at the end, and those were statistically positive results of those patients who were engaged in treatment at the end, because in the beginning there were only about maybe 12% of patients who were engaged, and at the end there were almost 40% that were engaged in treatment during the IF period. And when we looked at it really in detail, as you can see in this slide, that of the people who were engaged in treatment, these are the people who really received bup or no bup, because remember, they didn't have to receive bup to get engaged in formal treatment at the end. But those people who did receive buprenorphine, as you can see here, 19 of those 59, those patients were the ones who actually did more often get treatment. So if you received treatment, we received buprenorphine, we had almost 36% in treatment. If you did not receive buprenorphine, we had about 13%. And that's probably the most important finding of the study. And so we had some limitations, obviously, that the number of study sites limits generalizability of the findings. It didn't allow us to totally disentangle the IF effects from the potential time trends and the changes of ED-initiated view practices. And if activities in later sites benefited, obviously, from the experiences in the early sites, because we had to start one and then the other. And of course, we had to pause because of COVID. So we did decrease our enrollment. We were a little bit below what we had planned. It's also hard to really sink in that even though I went to all of these sites and gave this quote great grand rounds, a well-received audience with huge amounts of audience there from not just EDs, but people from the community came and everywhere else. And that people, I was there all day. It was your traditional grand rounds, which is a lot of data. But I was there, and if they asked me for any really specific things, if they wanted to know about, like they wanted to really get into the nitty gritty of what we did, I was prepared to go into that with them at any time. So in conclusion, all 4 EDs implemented the procedures and were able to learn about ED-initiated view. We clearly had an increase in waivers. That traditional grand rounds did not work. And in our observational cohort, more patients received ED view with referral post-IF. There was a significant side effect on that as well in that one site. And that was the New York site. Was not as significant as others, and that is New York. And New York, as everyone knows, has a lot of methadone associated with it and very easy access to methadone. Patients who received ED across all their sites were 3 times more likely to be engaged in addiction treatment on that 30th day post-enrollment. We have a lot of papers that came out of that, and I can share these with you with these slides. And they are all available, and those were our perspectives for patients and missed opportunities for HIV, et cetera, and models for care. So we really were able to disseminate a lot of information. Our main trial came out in 2023 and JAMA Network Open, as you can see. And so again, we can go over those. The other really exciting thing is that we found a lot of dissemination activities that we did during that, what David talked about. And so one of the more important things is we have Bupe initiation. You can download this anywhere on your phone, and it's updated now. We have updated it recently, and pretty soon it's going to have our 7-day injectable on it. But if you go on that thing, it opens up, and there are really 3 different things that you can see very clearly. And that's does the person qualify for having an opioid use disorder? And it actually goes through, and you can score it right there with the DSM-5 criteria. It gives you the opportunity to look at any of clinical opiate withdrawal scale. You can score it there. We use this in clinical practice often, just going to the bedside. And then it has this, the person willing to initiate Bupe or not. And there's some real important questions that you can approach the patient with to motivate them to change. And we also embedded this, which is very exciting, into the EHR, and Epic has embedded. If you have Epic, then you have all of the information that we have, and really with a touch of a button, you can see a patient and write a note. So I'm just going to go on to that. That's those 3 things with the Bupe initiation that you can see there. It's really easy to do, and it's a great reference. So please get all of your learners to just download that. This is our Epic clinical support, so that you can see, you can just immediately just press a button, out comes everything that you need here and their readiness. And you can adapt this to your site, so you can put in what are the most common places that you send people to. The order sets are there, so you can just press a button and it will order the medication for you. We have it at Yale. It can order this plus the 7-day injectable. And also it can write your note if you want to. And it says now that you've assessed the patient, they have whatever it is, severe opioid use disorder, their score was such and such, they were ready to begin, you gave them such and such, you gave them prescription, they were referred to wherever you referred them to. We actually here at Yale administer and dispense naloxone spray, and many places do that. And there are educational things we talk about regarding not using alone, et cetera, and a lot of harm reduction that just pop up in our printed and discharge instructions. So we had a few minutes, and I don't have a lot of time to talk about this, but just, we are now finishing, and we have finished 99, which was ED innovation. And this was actually compared to 69, which was a hybrid type 3. This was a hybrid type 1 in that it actually accentuated more of the patient effectiveness outcomes versus the implementation outcomes. We finished it, and I didn't have time to write everything down here, but I did want to tell you that we can come back and talk about assessing implementation reach and impact, because we presented this just this past week at SAM in many different formats. But I want to tell you that as of this, starting this project, it started in 2020 and then went to the end of 24. We have 55 emergency physicians that are board certified in addiction medicine. We have another 13 that are actually eligible to do that. They just haven't they've been approved to sit for the boards. We have 373 clinical and research staff that were trained, and we had 80 early stage investigators that led to the engagement of 19 additional funded projects since we had that, including 2 NIH Career Development Awards and 3 R01s, and lots of different things that happened. 15 of those sites have already implemented the EHR, and 4 of them are already giving out extended release bupe, and 54 dissemination resources were broadly disseminated over 116 external presentations for ED bupe, and there are 11 publications. So the implementation portions of all of this, which were done kind of with IF, are really amazing and have far greater reach even than some of the projects and some of the effectiveness outcomes that we had. And that was just basically it.
Well, that was terrific. The downside of a virtual grand rounds is that you can't hear the applause, but maybe we can check the reaction tab on our Zoom link. I want to open it up to questions. Now I have to distinguish between applause and a hand being raised, so that might not be the easiest thing. But I invite anyone in the audience to pose a question if you have one, or a comment.
Do we have anything in the chat?
So, Gail, great talk. Thank you for presenting it. I actually have a more practical question, because I mean, I understand that there's, David sort of went through the implementation piece, and he's like, a lot of work went into this, and there's a list of a few things, but I think it speaks volumes to the fact that you roll this out in a way that, not only works with what leadership at each institution wants, but also with the clinical providers and on multiple levels. So if you could speak to sort of the practical layers of what that looks like, I think that would be a really key component for all of us to sort of understand the intricacies of what you've had and your team have had to work through.
Right. So just remember, this was new. And so when we did it all based on the science that David went over, but you don't have to do that to create the wheel now. Like we did that, and now we moved on. So because of those dissemination techniques or whatever, we have all those available. And as I said, now Epic is here. So that does require sometimes getting IT people to talk with them and figuring out how to do it. But Epic has been great with it. They offer almost quarterly opportunities for any hospital to go through that and put it in Epic. I know it works. I give this story all the time, that there's one of my medical directors who gives out a lot of bupe in the hospital, and he called me once and said, "How much was that again?" And I said, "What do you mean you give out most of it?" Because he works in triage. And he said, "Epic's down. Just tell me the number, right? Just tell me what it is." So I know people are using that all the time. So we've done that. Again, we have that. We have in MD Calc and on the bupe app, people can use it all the time. And so there's not as much orientation or whatever that people are doing. And in all these sites, and in 99, we do have 29 sites that were enrolling, but we really had 35 EDs that we spread out the implementation to. 4 of them did not go on to the trial. But so in all of those EDs, Bupe is being used really quite appropriately. The problems we have are really trying to get smaller EDs to adapt it and to get, all you need is one champion, just get going. We also found out that we need experts that are live. So we're doing it, I've done it in Connecticut for our sister hospitals, about to do it to a few other hospitals, and wherever is, they need to have someone on the phone they can call. So when they get nervous, and that really has helped. We found this all throughout the country. So we're trying to get to regional parts where people can call. We say this all the time. There's 5 or 6 of us in different areas of the country, and just go ahead. They all have our phone numbers and call us. And there are other things. Equal is another study that's been going on here. Dr. Hawk and Venkatesh are the head of that. They're looking at small hospitals and rural hospitals and how to get them up and going. I've been talking to Team Health, exactly, that has a lot of different stuff that is not an academic site. They've taken over all of our stuff, and now they're initiated. So we're trying to spread it out in many ways that we don't have to reinvent that wheel that we did during 69.
Wonderful, thank you.
Other questions?
I guess I'll just respond to
I
what
had a
you
question.
were saying. I think you really have to identify the incentives at the local institution and then try to align your program with existing incentives. So it may be, amount of time that patients are spending in the emergency department that an ED administrator is very focused on. And you can say, well, if we're providing buprenorphine, these patients that normally would have stayed 24, 36 hours can now be discharged within 8 hours or 4 hours if they get started on medication. I think that, all politics are local. And so it's wonderful to have an individual who is committed to this area. If not, we observed, and you have to overcome this process of sort of death by protocol. This is the type of thing that folks know they should be doing, but they're afraid to. And so what they do is they set up 5 committees represented from 5 different perspectives, and they create protocols. And you find out that 2 years later, nobody's getting anything. You really need to sort of start at the end. And then this last point, I think that Gail mentioned, is something that 20 years ago we saw in primary care, which is that in all of these new practices of medicine, you need a colleague to be able to reach out and say, oh, remind me when I took that training, what should I do with somebody who has a COWS like this or has been using this? And so we created the PCSS and a mentorship system to sort of provide that level of support, not unlike you get as a resident and a fellow in a training program. And so those are informal. They tend not to be supported, but I think the field would move along a lot quicker if we thought about that as sort of providing formal support to sort of help people who are pre-contemplative or contemplative sort of move to the phase of action and start to do this. Because it's, once you do it once or twice, success breeds confidence, and you just sort of say, it's not as hard. I got over that initial initiation challenge, and now I can do this on a regular basis.
And I think in EDs, for ones, you can't change people's behavior. I've learned that when my prior alcohol, you can't change their attitudes that we learned in other alcohol studies, but we can change their behavior by making it easy. And ED physicians just want to get people in and out. So they do in this, they can be in a chair, they can be anywhere, and they're in and out in 2 hours mostly. And don't start with screening. That's my other big thing. People always start with that, and that's a non-starter. When you start to say screen, then everybody wants to know what I use for a screen, which is all different. And then who's going to do it. And the nurses get very angry because they have 60 screens they're supposed to do before a patient walks into that ED and they don't want any part of it. So all we say is forget about it. We don't screen. We see people, they come here asking for something, they come here with an injection abscess, they come here in part of the care when you're doing the H&P, you realize that the person has an abuse. Just start there and get moving. And then you can go back and try to find the more difficult patients, but they're right in front of you. But if you start with screening, you will destroy it and no one will do it. So just start with, I say identify the patient in any way you do.
I saw that Carmen Masson had a question, but now I can't see her, so maybe she had to drop off. Camille, do you have a question, or was that an applause?
I was applauding for the screening being a non-starter. I talk about this when in home visiting a lot too, because it not only can be a non-starter, but it can also like break trust. It also sometimes, like you said, isn't necessary. Like there's just, sometimes we already know, so why are we like using a screener when we know what the next best step might need to be? So anyway, I think that it's been a little bit oversold. There's definitely times when screening is helpful and necessary. I don't want to, as depression screening as an example, postpartum depression, we know that just screening alone actually confers benefits, but I think that sometimes that hinges on a lot of things that can cause challenges. So thanks for sharing. That's interesting.
Reed, did you have a question?
Well, I have a couple of crazy questions, if I can be permitted to raise them. These are really bizarre ideas that I can't get out of my mind. The first is I'm an addiction psychiatrist, and I'm puzzled by the fact that in Tennessee we have legislation that permits us to involuntarily commit people with alcohol dependence and drug dependence. No one will pay for it, of course, and it's also thought to be politically inappropriate. And addiction is the only the only syndrome in the DSM for that I'm aware of that we do not use involuntary commitment for, no matter what the situation is. And my crazy idea is that I kind of associate suicide with shooting up an unknown substance into your veins. I mean, it is death by your own hands. So that's my first crazy idea. We know that coercion can be helpful in the treatment of addiction from vast experience with physician health programs. And so that's one comment slash a question that I would raise to the group. The second point that again is a really crazy idea is that there's no talk about managing the demand for synthetic opioids like fentanyl and all those horrible derivatives that are going to be coming down the pike. We don't even talk about the demand on the streets. We're just going to bomb Mexico and invade China, and that's going to solve the problem. I think the solution is more to treat enough people that the demand diminishes. And the question that I have is, I have a terrible time on our inpatient service with people coming in with fentanyl who are having precipitated withdrawals. And I wonder what good we're doing resuscitating the same person on the street over and over and over again with naloxone, which creates a drug hunger, which is really the reason for the drugs on the street, because there's money to be made out of this demand. I wonder why we don't start thinking about using buprenorphine to resuscitate people. I mean, why it does precipitate withdrawal. I mean, I'm not a pharmacologist, but it seems to me that it would be very helpful, not so much to put the burden on the emergency rooms to initiate therapy, but to train the paramedics. And why not start right off the bat with using buprenorphine, maybe naloxone for the situation you're unsure of, because it's fairly safe. But those are my two ideas, and I'd welcome any reaction to them.
Well, Linda, do we have another hour and a half? I could get one of those, and David could take one. But just in terms of the EMS, I can tell you that we have a project right now going on, and there are many EMS programs, but there are three that I am working with specifically in it's 0154. And they are doing it right now in the field, either with a naloxone resuscitation and cows of 5, they initiate bupe. If the person wants it in the field, they do a really good job of that. They have a less than 1% precipitated withdrawal rate all over. If people are withdrawing and they call the EMS individuals, they also offer bupe on the street as well. For those people, it is people who are not using methadone for the last couple of days, so they don't want to precipitate withdrawal, of course. So they're having pretty good luck with that. They've got anywhere around 20% of people following up. And we're about to study that in a really better objective, observational way, in a pragmatic, non-randomized trial that's about to start later on, hopefully this year. We're doing the protocol development right now, but EMS people are attempting to do that. In the ED, we have, if you know, we have a huge boarding crisis. The ED basically is the healthcare system for the world right now, in the US anyway. And so we do not believe in coercion, but we do believe in motivation, and we have trained a lot of people to motivate. And honestly, when we look at our data on those people that we initiate buprenorphine with, they rarely, or any of our Project Assert in our substance use navigators talk with individuals, we rarely have them come back in 30 days. So we do really well by that. If people do not want treatment and you were to require them, they'd just be back on the street in 2 days. So our biggest issues are the unhoused population, which is really difficult. They're cohorted with a lot of people who are using, and they really have difficulty staying away from use because they go right back to where they are, where everyone's using. So we could solve some housing issues. We could solve a lot of things, but that's beyond me. And I think David wanted to say something.
You know, I'm sorry, I do have to intervene, and I think we do only have an hour, and we have a couple, actually maybe 3 other agenda items. So Reed, very provocative questions. I don't think you're crazy. These are wonderful ideas in service of the public health. So Dr. Fiellin, Dr. D'Onofrio, thank you for sharing your work, and we may very well take you up on your offer to come back and tell us more about 99. I think the using a hybrid trial, at least a hybrid 2, should be requirement, I think, at least for all of our work. So it's really fantastic that you applied that kind of approach. I want to turn it over to our work groups, who typically use this time to report out. I see Camille and Brian are both on. Maybe an update from the strategies work group, and it looks like Joe Glass is here and can talk about the outcomes work group. And I know Fernanda has an update on something as well. Camille, Brian?
Yeah, we are just trying to chip away at our review, and I have some action items that have been holding up the group so that we can get started on extraction, but we are in the full text extraction phase, if you will. We've passed the full text review stage and are assessing the papers that we've identified that intervene on stigma to see what implementation strategies those folks have used to try to intervene on that outcome in healthcare settings. If you're interested, I'll put my email in the chat. We're always open to new work group members. Brian, is there anything that you want to add?
Just to say it's nice to see some of our current work group members here, and I think even in Owen and Therese, a couple of our past work group members. We have had one or two people come back to us after a period of time off, and so I think Camille and I would welcome back any past members if they want to contribute to the prospective work there. Otherwise, just really nice to see everybody, Reed, Crystal, and Noel as continuing members, and of course, appreciated the presentation earlier. That's it.
Thanks, guys. Joe?
Sure, thanks. So I co-lead the implementation outcomes work group with Jennifer McNeely at NYU, and just a couple of things to share. As Mark mentioned earlier, we completed the systematic review of implementation outcomes within CTN studies over the past couple of decades. Sophie Gonzalez has been the lead of that work and has really kind of pushed forward some really good work. A few products she presented last year at a conference, at the Night of CTN conference. She has submitted the paper, the systematic review, to the JSAT special issue focused on CTN studies, and then she is just now submitting a request to the Publications Committee to review an abstract for CPPD this year. So as far as our work group has been really I'd say successful, and we have one product behind us. I think right now in the coming year, what we should focus on is really just getting back together and brainstorming, what should we do next? So I think it's really good to have a track record of doing a pretty strong project and completing it. And so, maybe we'll dive deeper into implementation outcomes and do more work in that area. Maybe we'll pivot. Maybe we'll look at another area of implementation. So I imagine that Jennifer and I will kind of regroup and have some discussions about that soon. Thanks.
It's always nice to see a work group produce work, and not just more thought and discussion. So both work groups, I think, are to be celebrated and affirmed for that. Fernanda, I know you had asked for some time, and it looks like you're here. So maybe you could share with the group what you were thinking.
Yeah, can I share my screen real quick here? Let's see. Hi, everyone. My name is Fernanda Rossi. I'm a clinical assistant professor at Stanford University School of Medicine and Stanford Center for Dissemination Implementation. I just wanted to make a quick plug for a brief online survey that Mark and I are conducting. This is an online survey examining perceptions of access to health interventions. Your participation would be extremely helpful to us if you have the time and interest. It should only take about 15 minutes or less, and you will get a $15 virtual Amazon gift card for your participation. I have the link for the online survey here, and Elena is going to send out that link to everyone after the meeting. And the information that you share on the survey is completely anonymous. We don't ask for any identifying information. So if you have any questions, please feel free to reach out to me or Mark. Otherwise, we really hope you consider participating in the survey if you have the time and interest. Thank you.
I think Dr. Vo suggests we put that in the chat. David, I know you had your hand up, and I didn't mean to be rude, but I'm trying to manage our time. Maybe you, since we do have a minute, maybe you could share with us what you were thinking.
Thank you, Mark. I appreciate it. Great to know of this group. And I think it's probably the group that can work the best with CCTN to make sure that the commercial research organization, or the CRO, that is contracted with CTN is as supportive and knowledgeable about implementation science studies. I think CTN probably started at a period of time where most studies look like a standard effectiveness study, an RCT, not unlike some of the algorithms that come out of pharmaceutical studies. But with a focus on implementation science, there's really a need to sort of look outside the standard box of RCTs and think about, how do you do a stepped wedge design? How do you do sample size calculations? How do you enroll not only patient participants, but also clinician participants? What are the types of metrics that are important to implementation science? So I think it's just an important contracting issue, and it might be valuable for this group to sort of survey lead investigators who have done implementation trials over the last 5 years within the CTN to see what support might look like moving forward.
Well, we believe in everything you've just said, David, and are doing some work in that area. So we totally appreciate it. I want to respect everyone's time. It's a minute before the top of the hour. Our next meeting, maybe Elena, I'll turn it over to you to just let us know when it is. I know we take the summer off, so it's in September, but when and at what time in September?
Yes, so our next meeting is scheduled for Tuesday, September 16th at 9 a.m. Pacific, noon Eastern. So wishing everyone a good summer, and thanks again to our wonderful presenters today and our work group leads as well.
Thanks, everyone. Have a great summer. Safe summer too.